regarding data sharing. And so I have, which seems to be the sticking point in a lot of collaboration here. So somebody mentioned the Pinellas Data Collective. So my question is, if you have a co-response model, do the social workers that are co-responding have access to that data that the officer or deputy may not have access to? Or would they have to be independent in order to have access to that data? I'm just trying to understand what would be available and to whom on site.
The answer is yes, they do have access to the information, the data, and one of the ways that we deal with it is just to get releases from people. When you ask, you get. And so, if the doors, we'll put it in a law enforcement, I guess, analogy context. If you got a search warrant and you're going to go in and the front door is unlocked, why do you use the sledgehammer? And so why we do it the hard way, just ask them. Majority of the time people will sign releases and we can get the information. So information silos and the lack of care coordination is huge. There's no question about that. And again, it goes with case management. But we do share information so that they are getting, the clinicians, the mental health professionals that are there with the deputies are getting information out of the variety of systems. But the problem is we have a variety of systems. The hospitals aren't connected to the community-based providers, they're not connected to the jail, they're not connected to the health department, and you got all these silos out there. So, we do share information and data, but it is a challenge. But how we get around it most often is that just ask these people to sign releases, and we have great success with them signing those releases.
So just to follow up to that, when you're coming on to the scene for the response, would the police also have access to that data, or only the mental health responder?
It depends what it is, and I know, and I wasn't in here for it, but I know you had a panel just a few minutes ago on HIPAA. HIPAA is one of those four-letter words that in HIPAA, FERPA, you can go down the whole list of them, and most of those laws are so misunderstood and misapplied. Unfortunately, is I also have the, I guess, whatever, of being a lawyer as opposed to, in addition to being a sheriff. So I used to practice employment law, so I'm pretty familiar with these things. And what I'm telling you is that with these, there's more exceptions than there are applications to them. And people over-apply this, and they talk, and most of the stuff in the law enforcement context, the stuff that we do, is that somebody gives us information that may be, health or mental health related. It's not HIPAA stuff when we put it in a police report. So there's a lot of stuff that we have access to that doesn't even trigger any of these laws. So I'll be honest with you, it's not a huge barrier. I mean, there is a barrier, but we figure out ways around it. And so it varies on the circumstances and the situation. So it's really hard to pigeonhole it, but information sharing, access to information, silos, I think are a bigger problem than anything else. That's my take on it.
Just to follow up on that, because we were talking about information sharing before you came in and all that, and from the law enforcement perspective, and one of the examples I gave is, if I'm a cop and I respond to a situation, I'm dealing with somebody with a mental health and or substance use disorder, I'm just a normal cop on the street, and I find out that they're under treatment, whether it's from a private provider or a community-based provider, and I want to reach out to them to find out what it is. They were telling that we can't, but to go off what you're saying is you ask for permission, but if this person is going through a crisis situation right now, they're really not somebody you can ration with. So is this something you follow up with later?
Yeah, this is where the immediate response team, so when they go out there immediately, they're going to assess the situation. If it is something, of course, where it's so bad where an arrest has to be made, then that goes down one path. If it's something where it is clear that there needs to be a Baker Act, then they're going to affect the Baker Act. But the whole goal, if we can, is to avoid either one of those situations. Leave the person in place with the idea that somebody's going to come back within a few hours or the next morning, and the follow-up teams and begin talking to family members, caregivers, etc., and begin the follow-up process. And that's where they're trying to get information, so they'll talk to people after things have calmed down. They'll get the release signed, and they'll start gathering the information. And that's where we refer them over to what we call the PIC teams through PICA, the Pinellas Integrated Care Alliance, and we get them into the case management, and so we're trying to get that information. So you're right. I mean, out there at 3 o'clock in the morning when the person is in complete crisis, you're not going to be able to get a release sign so that you can get access and share that information. So it comes in the hours or the days afterward that we're getting it, but we're getting it because we have the follow-up teams that are going back out there, and that's where it's working. I'm not saying that there aren't problems. I mean, we all know there's problems with information sharing and data sharing, but what I am saying we get around it more times than not by asking for releases.
Okay. Kind of jumping back over to the rural counties and the mobile response teams. Commissioner Harris, you had actually said earlier where there's additional funding now that can fund these mobile response teams. And like a lot of our counties, myself included, we're either finding some local public funds or I use relief funding to get the program up and running. But for these areas that don't have the money and they need to sustain it because eventually the startup monies are going to run out, is that money you talked about, is that reoccurring costs that they can get each year? Or is that basically just monies they can use to start up the program? Because then I could see down the road that, say that Sheriff Young is able to start a mobile response team because he gets some funding, and then that funding runs out in 2 to 3 years. Where is he going to get the money to sustain that program if in fact he finds it's working? Because our program's been up and running since January, and the numbers were astonishing as to the need for it. And so I got my county commissioners to buy into it, and they're going to sustain the program once the relief money runs out. But I'm trying to determine where can our rural counties find funding for such programs.
Thank you, Mr. Chair. Great question. So the $126 million that was appropriated for this fiscal year is recurring funding. So we worked with our managing entities as well as the Florida Behavioral Health Association to identify those areas of the state where expansion of mobile response teams would be helpful. And so where there will be new teams, those teams can be sustained into the future. As far as the need for even more teams, our goal, and I talked about this a little earlier, the needs assessment piece that gets done, I think that's where we really need to hone in. Where are the continued gaps so that when we're asked by the legislature, legislative staff, we have that information readily available. Also, I think we have finite funding, but to the extent we can pull that or use those dollars on evidence-based models, things that are working, it presents an opportunity down the road if we need to shift out dollars around to fund maybe a mobile response team as opposed to something else that is a little less effective, then we can do that if we have the right kind of data and information.
Secretary, now on the Northwest Florida, I think it's Northwest Florida Network, is that under the auspice of DCF? Because right now we're currently receiving funding from, and I think that's Mike Watkins. We're currently receiving funding for it now. Yes, thank you.
So what other gaps or what other areas can we help the rural counties in, and potentially suggestions for our legislators and governor the services we need to provide?
Well, I can't say enough about, the state entities that have come to our assistance, such as DCF and the entity I just mentioned with Mike Watkins. We're now seeing where we have a decline, especially as it relates to mental health. We don't see that 40% that was going into the jail that we saw. We see less now going to Florida State Hospital, mental institutions, even our Baker Acts on responding calls. We don't see the number of Baker Acts as it relates to the recidivism. When they recidivate, these people get out of jail. We're not responding to those different calls of Baker Act. One of the issues we see is some of the minor crimes that they're committing, such as trespass and all of that, and showing back up to the jail. Well, now they know there are resources out there. I know one of the entities, Appalachia Center, they know that now they could go to these places to get the help that they need.
Great. Commissioner Nankowski.
Yes, one more question. When you brought up Baker Act, we also had a panel earlier, I don't remember when, it's been a long day. And they were mentioning that that people were being brought in under the Baker Act when they perhaps should have been brought in under the Marchman Act. And I just wanted to ask you, what kind of training is done so that people know which one? Or if they have any input on that?
The answer is none. Is that you can't ask cops to do a differential diagnosis on the street. And that's what the problem is that, they're not trained. So in the police academy, look at the training that people get on mental health. It's virtually nothing. It's literally a few hours. And so then you put them on the street and you're asking them to deal with this in an effective way. And the CIT model, Crisis Intervention Team model, which is 40 hours of training, generally is not done until somebody's been out for about a year. And that's generally when they go. You do have mental health first aid courses, but that's 8 hours. I mean, and basically that is open your eyes, and there might be something more to this as to why that person acted than criminality, and try to get them to make a better decision. So it's really impossible in many cases to ask that cop to differentiate between whether somebody should be. And the model I think that works around the state, and I don't know anybody else that has it, and it's because the county invested it in Orange County, and they have the central receiving facility over there, so it's one-stop shopping. The cop doesn't have to decide. What the cop has to do is look at the situation and say, this person did something. And I know based upon what they did, and it may be a crime, but it's driven by something else, or it's social crime and it's so minor that they're not gonna worry about it. But I don't have to figure it out. What I have to do is get this person from here, point A, to point B, to the central receiving facility. Then they figure it out and they get them in the right lane with people who are qualified to make that decision. And if anybody thinks that we can get law enforcement in this state into a situation where they can make that distinction and get those people, it's not the path to go down. It's never gonna happen, and it shouldn't happen. So you need people out there that either can help with, again, the co-response model would be helpful, but there's only so many. We have challenges in hiring. And you all know, within the mental health profession is that it's a big challenge to hire people. So, a better way, I think, is to go toward a central receiving facility type model where you don't have to have, you can have 10 people there who work there as opposed to 50 in the field. And so that model is the better model. And also, like, the problem you have with Marchman beds. So in Pinellas, we have 0 state-funded Marchman beds. We don't have any. So you know what the Marchman facility is in Pinellas? The jail. And so what do? Is that we bring them in, we throw them in a cell, and when they're no longer drunk, we throw them out the back door. They don't get any services, they don't get any treatment. All they do is sober up to the point where they're not drunk anymore. And so none of that's good.
All right, thank you. I got Commissioner Reed online. Do you have a question, sir?
Sure, can you hear me? This is AJ Smith.
Yeah, sure, Smith. I'll get with you in a minute. We got one more question.
It's a question, observation of the question, Mr. Chair. Thank you. First of all, I wanted to say hello to Sheriff Young. Appreciate your partnership as well. The programs Sheriff Young was talking about, as he noted, are ones that we partner on and collaborate on. And that is sort of leads to my question for all 3 panelists. I think there's different models across the state. We've tended in the Northwest to pursue partnership and embedding models where we have community mental health center clinicians working directly in the jail and with sheriffs and through the mobile response teams. It sounds like Sheriff Gaultier and to a certain extent Sheriff Lima, the models that you're pursuing are ones that are more housed within the sheriff's department. So I wondered if you could speak to the preference for doing that, rather than a partnership model, or in what ways does conditions differ?
Yeah, thank you for the question. I think the partnership model, at least for me, is kind of the best path moving forward. You've got a lot of common interests, in connecting the dots, as long as the law does not work against us. And like Bob said, there's a lot of misinterpretation of HIPAA requirements where people go out of their way to make sure that they're not collaborative. When it comes to the model that works, I think that the geographic area of responsibility has a lot to play in that. Like in Seminole County, I haven't invested much in the co-response model. I think that the response model in lieu of police potentially is incredibly dangerous. I think that disproportionately we know people in crisis can act out violently. But I do see an application for the co-response model. But, you know, I think that people forget how many numbers in Seminole County. You know, we're a small geographic county, 350 miles, 500,000 people living there, 7 municipalities. We do about 3,600 Baker Acts per year. And a good percentage of these people are repeat, frequently involved in the system. And when you look at 3,600, that's a big number. That is a big number for a crisis co-response team of 5 or 6 or 10, even 20. Once you weed out working hours and shifts and response times and trainings, you don't have a whole lot of opportunity to respond out and get it out there. I know it worked for some, but the model that we're putting together is the one that Sheriff Gualtieri mentioned with the Orange County model, where you actually take them there. Part of our legislative efforts this year are going to be to make sure that we do all that we can to clean up the law that allows us to bring them to a location to be evaluated by a licensed clinical worker at a convenient location that's open 24 hours a day, 7 days a week, and not opine those opinions on the street by practitioners that are laymen at best in determining what really is wrong. At these locations, you can also connect the dots because there's people that may be entitled to VA benefits, there may be insurance coverages, and that is an incredibly difficult system to navigate. So I think it kind of works best, but one of the things I want to leave you with is you absolutely have to know what your numbers are. And in most jurisdictions across the state, if you ask the leaders of those areas, whether they're the mayors or whoever it is, give me the number of people who have been involuntarily admitted in your area. I think it'd be incredibly difficult for them to even give you a number.
Thank you.
So we do about 12,000 Baker Acts a year, and it's of course not 12,000 different people, but most Baker Acts, when you look at the numbers in the data of the Baker Acts, most of them are one and dones. The majority of them are 1 or 2s. The majority of them are not your 4s, 5s, and 6s. But you know, again, you're dealing with the chronic population. I'll go back to where I opened. Is that with the chronic population, if you want to change the cycle, it requires case management. There's just an unrealistic thought, I guess, that these people can do this on their own, and the case management they're getting is individualized case management with a provider. And it's not true case management, not master case management. Something else I want to tell you, and some of you may not be aware of this, that goes back to where the system really needs to change. And I hope that something is driven from this commission on that. In Pinellas County, and I don't know of any other law enforcement agency in the country that is doing it, not to the extent that we're doing it. Because we're dealing with a chronic homeless population. And we know the chronic homeless population is largely co-occurring disorders. It's mental health, behavioral health, substance abuse, and that's why they are chronically homeless. The Pinellas County Sheriff's Office is the largest provider of homeless services in the county. We run Pinellas Safe Harbor, which when we opened it in 2010, went from 0 to 400 people a day as an average population. And it's keeping them out of the jail. And we're doing all we can, but we lack our services and we lack case management. So some of those people are there for a very long time. But again, it goes back to why are we as the Sheriff's Office, and we have our own mental health counselors, we bring people in for literacy and job training and drug treatment and all the services, social workers and the whole gamut of what you need to do. But why are we doing it? Because nobody else is doing it. And I tell you, you know, we learned how to do it. But I've offered this for the last 12 years now, since we opened Pinellas Safe Harbor. If anybody wants to come and take it over and run it, I'll give it up. But nobody's taken me up on that offer in the last 12 years. But we're doing better by people. The average daily cost to house somebody in the Pinellas County Jail is about $157 a day. We're housing people at Pinellas Safe Harbor for $17 a day. And we're keeping them out of the jail and out of the criminal justice system. So it's the right thing to do, but we're not experts at it. Somebody else should be doing it.
All right, just I want to check in with Sheriff Smith joined us. Sheriff Smith, floor is yours.